Well, I am so excited to introduce our speakers this evening, and I'm really looking forward to this really informative and very important presentation. Our first speaker is Dr. Cassandra Duran. She started her nursing career 16 years ago. She graduated with her associate degree in nursing in 2007 and her BSN degree from Texas Tech University in 2009. She went on to receive her master's from Texas Women's University in 2013 and her doctorate in nursing practice from the University of Texas Medical Branch in 2019. She's worked at the Texas Children's Mobile Clinic program for the past 10 years. She is an assistant professor at Baylor College of Medicine and academic general pediatric section. She is a busy mother of 4 who loves reading, working out, and traveling. Also, we're so pleased to introduce Norma Castillo, and she has been in her nursing career for over 10 years. She graduated with her bachelor's degree in nursing from the Houston Baptist University in 2012. She later received her master's from the University of Texas Health in Houston in 2020. She's worked with the Texas Children's Hospital and the Texas Medical Center for over the past 8 years, and most recently joined the Texas Children's Mobile Clinic in July of 2022. She is a clinical instructor for Baylor College of Medicine in the academic general pediatric section. She has a very busy and fun toddler named Olivia, a supportive husband, and has 2 pups that she loves to spend time with. So thanks so much for being here, and I will mute myself.
Thank you so much for the introductions, Christy. We're going to go ahead and get started. So tonight's talk is immunizing the newly arrived pediatric patient. Before we kind of jump in there, I kind of wanted to give you a little bit more history about Norma and I. I'm Dr. Duran. My colleague and I will be giving this presentation, Norma Castillo. We are both mobile clinic providers. We work on Texas Children's Mobile Clinic. So basically what we do is we have a few mobile clinics that go out to different areas in the Houston metropolitan area. And we provide services in these under-resourced areas across Houston. So the majority of the services that we provide are vaccines. But we also do well child checks and ill visits and LTBI visits and what have you. But like I said, the bulk of what we do is vaccinating, newly arrived immigrants. We get patients from all over the world. From any country you can think of. Most likely they've, probably been, to our mobile clinic, right? Once they get here, we see patients from Afghanistan, Iraq, India, China, Cuba, Venezuela, Colombia, Guatemala, etc. So over the years, we have gotten very comfortable reading shot records from around the world. What we do is very gratifying and rewarding. Each night when we go home, we know that we have done, we fulfilled our good deed for that day. And it just keeps us coming back for more, right? I've always said that I wanted to do missionary work. And thankfully with what I do, I feel like I'm able to do it, in my own hometown. Next. Thank you. So our learning objectives for tonight are to identify the newly arrived pediatric patient, learn how to read foreign vaccine records, and use the CDC catch-up schedule to determine what vaccines the patient might need. We do not, I just want to mention, we do not have any disclosures to disclose. Next, please. Thank you. So the newly arrived pediatric patient, the term immigrant child is used to describe any child or children that are born outside of the U.S. Children in immigrant families are children who are foreign born and those who are born in the U.S. but have at least one parent who is foreign born. Refugees, on the other hand, are children or adults who fled persecution from their home countries and legally enter the U.S. after being screened and approved by U.S. agencies. So those are like, they give them basically permission to come in. Asylum seekers is the status that we give to people that are already here, but they have a fear of persecution by or permitted by their government on a basis of 1 to 5 grounds, and they satisfy the requirement for the refugee status. So the asylum seekers, are basically the ones that are here. The refugees have actually went through the screening, and then they're allowed to come into the country. But basically, any child born outside of the U.S. is an immigrant child. In our mobile clinic, we consider a newly arrived pediatric patient anybody who's been in the U.S. for less than 1 year. We say that they're newly arrived. Next. So it's estimated that about 2.5 million immigrant children live in the U.S. So if you haven't encountered them in your practice, most likely you will at some point. And it's really important for us as healthcare providers to understand the best practice guidelines for their care. The AAP actually has a immigrant toolkit that's really useful, and you can refer back to it, like if you do have an immigrant child, that you're trying to tend to or care for. And the reason why this topic is so important is because over the past decade or so, healthcare of children and immigrant families has really received lots of attention. And so the reason it's been receiving lots of attention is because as far as like population wise, we are seeing more and more and more immigrant children in our, in the US. It's projected that by 2065, 18% of US population will be foreign born, and an additional 18% will be US born children of immigrants. So it's really important for us as healthcare providers to understand this and to know how to take care of them. Next, please. Thank you. So 1 in 4 kids, children in the US are children in immigrant families. Like I said, they are the fastest growing population of children. More than half of them live in these states: California, Texas, Florida, New York, Illinois, New Jersey. But like we said, they are fast growing. So just because, you're maybe in a different state from the ones listed, it's still important for you to understand, how to care for these children, because, most likely you will encounter them at some point in your practice. And so next, please. Why do they come to the US? So they come for a variety of reasons, but mostly it's economic opportunity, educational attainment, family reunification, and safe haven from violence or persecution. So, over the years, I've heard, many, many stories about why it is that they left their country. I hear, sad stories about there's not Tylenol to give the kids. There's no, cancer medications to treat, cancer patients. There's no doctors in the hospitals. There's no nurses, like classrooms are empty. Just in different countries, things are not great, right? And so they come here to seek a better life, to have better opportunity for themselves and for their children. Or sometimes, the family, the mom or the dad comes and they leave the child with grandma or grandpa or another type, another family member. And then, once they are, stable and ready, they ask for the child to come, right? And sometimes these kids come unaccompanied. They come alone, but it's, with a goal of reunifying the family, right? And sometimes, you hear, Norma and I both hear lots of stories about the violence, in other countries. There's lots of gang violence, lots of cartel, sex trafficking, just a lot of things like that. And, what happens is once like somebody in the family either dies or gets threatened, they don't sit around and wait to see what happens, right? They usually gather whatever belongings they can and they come, they just kind of start making their way, to the US. But what happens is because of this, they don't tend to get their shot records or any kind of medical records. That's not really, they're like in a fight or flight mode. So, all they're worried about is, just, keeping their family safe. So a lot of the times they just leave all that stuff behind because they're just trying to, make it to safety. So unfortunately, without a vaccine record, there's no proof that this kid actually got all the shots that they did, when they were a baby or, in their childhood, right? And so, if they don't have a record, then we're not able to count the vaccines that they got without any proof. But my point is, a lot of the times they are just fleeing their country. And so that's why a lot of them do not have a vaccine record when they come to this country. Next. So initially, when the immigrant child gets to the U.S., they do tend to be a little healthier than their U.S. counterparts, and healthier in the sense as like normal weights, normal heights, normal BMIs type thing. But this advantage tends to decrease over time. And then they become more vulnerable, right? They have lack of access to care. Other social determinants of health kind of affect their health, right? A lot of them are they live in food, they have food insecurity in the home. So it's, what I also have noticed is that, when we get these newly arrived, kids in our clinic, most of them have never had a well child. If they've ever been to a physician or to a hospital or to a clinic, it's usually because they were sick, they were really sick, or it was to receive vaccines. So a lot of the times they don't even know what a well child is. So once we explain it to them and we tell them, well, it's actually like, we're going to check, their vision and hearing, height, weight. They're like, oh, well, yeah, they've actually never had that before. So it's quite interesting. But, so basically, like once we're able to get them in for a well, we're able to provide them with lots and lots of education and lots of resources that they've never had, in their entire life. And because we are a mobile clinic and we do get lots of newly arrived immigrants, we are usually the first healthcare provider that they see in this country. Honestly, to myself and to Norma, it's an honor. It's an honor to see them, to treat them, to care for them, to provide them with a warm, friendly welcome, to our country, right? Like I said, I've heard lots and lots of stories of what brings them here, and then I think to myself, things had to have been really bad for them to just pick up their entire family and move to another country, that they don't speak the language, they don't, they don't have family support here, they're not sure, about the school system or about work, or, it just makes you wonder, like, how bad was it that they actually had to leave their country? So like I said, it's an honor to welcome them to our country, and I try to make them always feel safe and welcome. And yeah, I'm so sorry. I'm sorry. Yes, so I always, anytime that I encounter them, especially when it's their first time, I just, we try to be as welcoming as we can possibly be. Next. Great. Okay, so why do we vaccinate? I mean, I'm preaching to the choir. You all know why it's important to vaccinate, but here are some reasons. Because vaccines have saved lives for over 100 years, because they're the best way to protect ourselves and our kids from preventable diseases, because they prevent serious illnesses, they're safe. And number 5 is really, really important. And it's actually kind of what brings, our newly arrived immigrants to our clinic, because they're usually required. They're usually required by school, by work. And so when they come to us, it's usually because they need vaccines, and they need these vaccines in order to be enrolled in the local public school system. So usually the school nurse will refer them to us, or a family member, or another clinic maybe. And so once they do get the required vaccines that the state of Texas does require, then they're able to put the child, in school. And then this child is able to receive 2 meals a day, breakfast and lunch, Monday through Friday. Because like I said, a lot of our families are food insecure. They live below the federal poverty level. And so, you know, a lot of them don't know really where their next meal is coming from, or, you know, they take kind of side jobs, you know, odd jobs like day jobs. And so, you know, money is always an issue, you know, for our families. And typically, just in general, our, you know, our patients are not, they don't tend to be anti-vaxxers. They don't tend to say, oh no, that's too many vaccines that we're giving today. I don't want my child to get 10 shots or 9 shots today, because sometimes that's what we're doing. You know, if they're an older child and they don't have a record, you know, we're having to start them all over. And, you know, it can be a lot of vaccines that we're giving today. But it's really nice that you don't have to convince them as to why they need the vaccine. They're usually pretty accepting of it. And they're, you know, also from other countries, and they know how scarce resources are in their country. So they're really, you know, thankful that we're, you know, providing these kind of services to them. Next, please. So what foreign vaccine records are accepted? So they have to meet all of these requirements. The vaccine record has to be transcribed to a universally acceptable language. So, you know, we have to be able to understand what vaccine it was that was given. And sometimes they're in Spanish, or they're in Chinese, or, you know, in Arabic. But as long as it has like DTP, you know, it could be written like, you know, in their language, but as long as maybe like in parentheses, it'll say what vaccine that was. And usually you're able to understand what those initials, you know, stand for. They also have to have, you know, dates that are written in pen, not in pencil, or they can be typed, and it has to be on an official immunization form. Also, the timing between the administration and the vaccine type has to be acceptable by the CDC, and it has to have the patient's name and date of birth. So if it has all these 4 criteria, then you can accept it. We can accept the record, because vaccine records are actually accepted in any country. So, you know, a lot of the times we get, you know, families and they're like, well, they don't want to take this at the school, or the school nurse says she doesn't understand it. Actually, like if it shows what vaccine was given on what date, you know, with the child's name and their date of birth, it is an acceptable record, you know, here and in other countries. So if it does meet those requirements, then we would only give the child what they need from here on out. So they would be put on the catch-up schedule. But we would count all of the, you know, the vaccines that were given in their country, as long as they meet all of these criteria. Next, please. Oh, I'm so sorry. So here, the rest of the session is going to be interactive. So if you wouldn't mind pulling out your phones and scanning this QR code. And once you scan it, you can kind of just keep your phone on the side of you, because we'll be asking, you know, quite a few questions throughout the rest of the presentation. Norma? So it says, 1 second. So Norma, it says it's waiting for the host to start for the QR code. And then on each slide, there at the bottom of the screen, there's a QR code. There we go. And so thank you. And so if for whatever reason you get kicked out of this poll, you can, you know, scan it again and get right back in. So, you know, these are 2 vaccine records that we commonly see in our clinic. Would you all think that these vaccine records are valid, and are they legible? Just take a minute and kind of answer this question on your phone. Okay. And so actually, yeah, so 77% of y'all said that yes, they are valid, and that's the correct answer. So this one on the left, a lot of the times they give us a copy of the record, and so maybe it looks like this picture on the left, but sometimes it looks clear as day, like the picture on the right. Just some things that I want to point out to you guys is Usually in other countries, the date is written differently from the way we write the date. It's usually written it's usually written day, month, year, as opposed to month, day, year. When you're reading records, you kind of have to kind of train your brain to read it backwards, right? So like this first shot record on the left, the second vaccine that was given, the first one was BCG, and that really doesn't, affect us here in the States. The second one that was given was polio and pentavalente at 2 months of age, and that was given December 9th of 2011. So you kind of have to read it a little differently, but I can go through and I can tell you that I can read every vaccine on every line, and I can actually make out the dates on the right side. It's not very clear, but my eyes are kind of trained, and you can see that there are dates, and there are months, days, and there are years there. So you just kind of have to make out, what it is that you're looking at. This vaccine record on the right is actually a lot clearer, right? You can see hepatitis B on the top, the very pink, the pink line on the top was given September 17th of 2020. And then you can kind of go down and you'll see, the BCG, the polio, the penta, the pneumococcal vaccine, the rota, the flu shot, which they've never gotten a flu shot, the SRP, and then the DPT. But sometimes they're not very clear, and sometimes they are. If at any point you're questioning, like, what is that shot? What is that date? I can't make this out, and you don't count it, and then you would just, give them whatever it is that they need. But both of these records are legible, and they are valid. So what happens if they didn't come to the country with a shot record? Well, you can do serum testing for immunity, but it is actually really expensive. Most of our patients, like I said, they live below the FPL. These testings are really expensive. But in the end, the only thing that you can be tested for are hepatitis A, hepatitis B, MMR, and varicella. So, not polio, not your tetanus, not your pneumococcals, your HIVs, your meningitis. I really have never seen any of our patients get the serum testing for immunity. So that is an option. But the other option would be to start them all over, to give them all the shots that they need, like from a blank slate. And that's typically what we do a lot of the times. And so most of the families, either leave their records at home, or they do bring them. They had enough time to kind of gather all the documents that they thought, that they would need, and they do bring them. But, they have to cross multiple countries a lot of the time. So they either lose them on the way, or they get picked up and they go to like an ORR shelter and they take them away for whatever reason. That's, a common thing that I hear. Well, they took it away from me in the shelter, and, they usually don't get it back. Another common thing that I hear is, well, I gave it to the school nurse and she didn't give it back to me. So it's a lot of education that we do with the families. I always tell them, like, before you leave today, take a picture of this shot record so that if you misplace it or you lose it, you have it on your phone. And so, I always educate them, like, this is your child's like record, like nobody should have it but you. You should keep it in a safe place. You shouldn't give it to anyone. And I also educate them, and I ask them, well, is there anybody back home that can send you the record that was left behind? Is there any way you can call the doctor's office? Is there any way that they can fax it, mail it, text it, send it through WhatsApp? Is there any way that you can get a copy of that record? And sometimes the answer is yes. Maybe we can't get it today in clinic, but maybe for next time when I see you next month, maybe you'll have it, and your kid will not need, 6 or 7 shots. Maybe now they only need 2. And I tell them, that if they can print it, they can go to Walgreens or Kinko's or wherever it is that has a printer and get that printed out. And then we'll put, that with the shot record that I give them today. And so a lot of the families have done that. And it's really good because we're not wasting resources. We're not over vaccinating this child. It is a traumatic thing to be giving a kid, 9 shots, right? So that's really important to ask them, to get copies of their record, even if it's in another country. Next, please. All right, so what you see here is a blank shot record. It is the state of Texas shot record. So if I were to see an immigrant child in clinic today, I would fill it out, and I'd mark everything that I gave them today. I'd put their name and their birthday, and I'd say, this is their record, right? But before I would give the vaccines, we would look in our state registry system. So in the state of Texas, we use what we call IMTRAC. So each state should have their own database where, vaccine records are kept. So we do take a few minutes to look them up, because sometimes, like I said, they're in a shelter and they're given vaccines in the shelter. And if they're given vaccines in the shelter, sometimes you'll find them in IMTRAC because maybe they didn't get a record when they were released from the shelter, or they did get the record and it was within those 100 pages that they were given, and they don't know, which of the 100 pages is a shot record. So sometimes, I'll be like, give me the packet, and we look through the whole thing and it'll be like the last page. And then I'll be like, well, this is actually, their shot record. But so sometimes you'll find vaccines in IMTRAC. So it's really worth the time to take, the time it takes to look for them, because sometimes you'll find it. And like I said, so I take a lot of time to educate them, and I educate them not only like to get a record from their home country, but also not to separate records. So they'll come back the next time and they'll bring me this record that's on your screen. And I say, well, what happened to the other record? Well, that's the one you gave me last time. So I don't know what happened to the one from my home country. And I'm like, no, we need that record. All of these records have to stay together in order to make a complete record, because this, alone is not a complete record, right? So I take a lot of time to educate them, to not take them apart, to not give it to the school nurse, just to give them a copy, because, if we don't tell them, they don't know. The last thing I want to do is over vaccinate a child or misuse resources, right? And sometimes they come back and they tell us, well, the school nurse says she can't read my record from their home country. And the school nurse doesn't want to take it. And, she says she doesn't understand this record. And so they ask us to transcribe the record. So put whatever vaccines they got in their country onto this record here. We try not to do that. Because some of the times what we've noticed, like when we do transcribe, we mess the dates up, we don't transcribe it right. If we started doing this, we would have to be transcribing for records for everyone. And it's a lot of patience and it's a lot of time. So we're not able to do it. But if they're really having a hard time, we usually tell them to go to their consulate and have it transcribed. We also send them to their consulate if it's a record that I can't read, or that we can't read, like on the mobile clinic, because it's still in a foreign language and I'm not able to read that language. Then that's what we ask them to do. Next, please. So this is just the regular CDC schedule for the vaccines for kids from birth to 6 years of age. I'm sure you guys have seen it a million times, and I'm sure you guys are pretty comfortable with it, right? The thing with this is kind of what I wanted to point out was in a lot of other countries, kind of like if we backtrack, you don't have to go back, Norma, but if we backtrack to those two vaccine records we saw, the one on the left and the one on the right, if you saw, the child was vaccinated quite frequently, right? And so their shot record was very similar to this schedule right here. So in many countries, it's a very similar schedule. It's not like totally completely different. It's very similar, but there's some things that we do differently here than that they don't do over there in their country. Yeah, I just wanted to point that out. Next. This one here is the regular vaccine schedule for kids 7 to 18 years of age. The adolescent vaccine schedule is a little different in other countries. I really haven't found too much of a similarity there. But this is, I'm sure you're pretty familiar with, like your adolescent vaccines that we give at, 11. Yeah, so we can continue. Please. All right, so we'll go back to that, to our little poll. But this is a 6-month-old baby that we see in clinic today. We're solely looking at hepatitis B. And right here on the right side, we have the patient's date of birth, and then we have the 4 doses of hepatitis B that the child received. And, excuse me, do you think that they're up to date with the hepatitis B vaccine? So you can answer on the poll. Okay. All right. So 80% said no, and you're correct. And so the reason that they're not up to date is because the first dose has to be given at birth. The second dose, so this is based on the catch-up schedule. So it's not, based on the schedule that I showed you that you're going to get at birth 2 months and 6 months, right? For the catch-up schedule, you're going to get a first dose at birth. You'd get a second dose about a month later, and you'd get your third and final dose. It'd have to be 8 weeks after the second dose, but 16 weeks after the first dose. And they have to be at least 24 weeks of age. So if we go back to this slide here, you'll see that the child received a birth B. They received one month later, and then and they received a third one a month later, and the fourth one was another month later. So the intervals between doses 2 and 4, between 3 and 4 are too close. So that last dose has to be at least 8 weeks from that second dose, and it's not. Well, actually, I'm sorry, it is actually 8 weeks, but it has to be 16 weeks from the first dose, and the baby has to be 24 weeks. So that last dose couldn't be given until like the baby was 6 months of age, right? So maybe until about May is when that final dose of hepatitis B should have been given. So for this baby, you would have to redose them with another hepatitis B once the interval is good. Next, please. So let's take the poll out again and answer this question. So looking at the shot record, is this 10-year-old patient up to date with their hepatitis B vaccine? Sorry, hepatitis A vaccine. So kind of take a minute just to look at it, and then you can answer the question. So on the first row, you have your DTaps. On the 5th row, you have your polio, then you have your HIV, then your MMR, followed by your hepatitis B, your varicella, and your pneumococcal. So you'll answer. Okay, perfect, 100%. So are they up to date? No. And this record, to me, it looks very complete, right? So they've got their 4-year-old DTaP, they've got a 4-year-old polio, their MMRs look good, their varicellas look good, their Hep B's look great, but there's no place for Hep A. So the child does need does need a hepatitis A. They need to start the series. So with hepatitis A, it's a pretty simple vaccine. You start at 12 months, and then you have a 6-month interval between 1 and 2, dose 1 and 2. You don't give it, before the 6 months. So if you give it January 1st, you're going to give it again July 1st. You don't wait 24 weeks. You literally have to wait the 6 months. And so if we go back to the shot record, you'll see that there's not even a place for the hepatitis A. And so for the reason that there's no place for the hepatitis A is because it's only required in about 17 states in the US. So this record here is a Florida record. So it's not required in that state, so there's no place for it. But, given that, we're in the state of Texas, if they were to come here and I'd look at this record and I say, you know what, you need hepatitis A, they would start the series today. And then I would say, come back in 6 months, which would be anytime on or after November 10th to get their final hepatitis A. Next, please. And so here we're looking at this top vaccine. You'll pull out the poll again and have it ready. But is this SR vaccine acceptable? And so remember how I told you to read the dates? You're going to be looking at first 24 is the day, and then the 4 is the month, and the 12 is the year. So that's April 24th of 2012. They received SR. So SR is your measles and your rubella. Is that vaccine acceptable? Okay, so about a third of y'all said it is, and then 2/3 of y'all said it's not. So it's actually not. And so why is it not acceptable? Well, for MMR to be accepted, for the MMR vaccine to be accepted from other countries, it has to have all three components. It has to have the measles, the mumps, and the rubella. And that shot record, it didn't show that, you know, all three components were there. It only showed the measles and the rubella. So it's really important for us to find, you know, that it has all three components. And then if it doesn't, you're just going to redose it. As far as MMR, the catch-up schedule, the minimum age is 12 months. Sometimes you see it given at 6 months, at 10 months, 11 months. Sometimes they get it a week before they turn 12 months, and you would actually redose that. And the interval between the 2 doses, it's a 2-dose series. It has to be at least 1 month. So next, please. And from here, my colleague Norma will be taking over and finishing up the presentation. Thank you.
Thank you, Cassandra. Just a reminder, the QR code, if you want to keep participating in the interactive, is down here in the corner. You can keep scanning it if you get locked out or whatever happens. But we'll go ahead and look at the next question. Does this 7-year-old patient need a varicella vaccine today? So we'll open up the poll here. And if you take a look here, there is a dose and pen, very clear, 3/17/21. And there's a note of history of varicella on March 7, 2012. So pretty clear. We ended up even stamping it, so it's very clear what was given, and also a history. Let's stop the poll. So no, this patient will not be getting a varicella today. So let's take a look why. So the patient did get the vaccine at least at 12 months of age, like we saw on the record. There needs to be a minimum interval of 3 months between the doses if the child is less than 13 years of age. However, if they were given that second dose 4 weeks apart, we can go ahead and count it. However, because there's a documented history of varicella, we'll go ahead and count that as they're exempt from receiving the varicella vaccine today. Like you saw, there is it's written clearly in pen. If there's a doctor's note, we'll go ahead and count that as well. That states that the patient had varicella at some point. We usually try not to take a verbal history from a parent. Sometimes they confuse the sibling with another one, or they're not really sure of the date. So we like to have something written to go ahead and count that as a history of varicella. So for this patient, because they received one and there's a documented history, they won't be getting a second one today. So that's for varicella. This next question will open up the poll. Is this 6-year-old patient up to date on DTaP? So DTaP in this case for this record is written out as pentavalente, which is DTaP, Hep B, and Hib component. It's a 3-in-1. And we can see there's at least 4 doses documented. We have the date of birth of 10/25/16. A couple of doses were given about 2-3 months apart each. And that final dose, the patient was about 2.5 years old. And we'll stop the poll here. So is this patient up to date? So unfortunately, no, they're not up to date. They'll be receiving one today. Let's take a look why. So that minimum age, again, 6 weeks of age, and we had to have waited at least 4 weeks, which you do see the interval is the way it should be. However, that last pentavalente with the DTaP component, the patient was not at least 4 years of age. So they only need 4 doses if all components are present, which is kind of like what we talked about with the MMR vaccine. Sometimes you'll see like only SP or SR. And with DTaP, sometimes you'll just see like DT. We want to make sure that has all the components, which the pentavalente does. However, if they didn't receive it on or after their 4th birthday, they won't be valid at this point. So this patient, like we saw, they weren't quite 4 years old. So they'll go ahead and receive the 4-year-old catch-up schedule today and then be up to date. Next question, we'll go ahead and open up the poll. This one is a little bit of a different record. Is this 12-year-old patient, or does this 12-year-old patient need a Tdap? So you can see with the arrow on that row, if you follow along, dose 1 was given November 8th, 2022, and dose 2 was given about a month later. Will they need a Tdap? So yeah, very similar to the DTaP, because that full component of Tdap wasn't included, that acellular pertussis was missing, the patient will be required to receive another dose. So similar interval dosing between the doses of 4 weeks. There is a 4-week interval between dose 2 and 3 if they received a DTaP before their first birthday. However, there'll only be 6 months as the final dose if the first dose of DTaP or Tdap was administered on or after their first birthday. So this patient here was about 12 years old. They'll have to come back in 6 months to receive that Tdap with the full component. You can see the check mark on the TD, and we'll make sure that the next time they come in 6 months after that December date, that they'll get the Tdap, the full component. Yeah, we'll move on to polio and open up the poll here. Are these polio vaccines valid? So this is that super clear record. It's typed out. The dates are very legible. Date of birth for this patient was September 17, 2020, and they received 3 doses. All kind of, again, like 2 months apart from each. Would we count those and move them on to their next record? Okay, so we would not count them. Let's take a look why. Even though it's like very clear in pen, the dates are written very legibly, they would not count. So for polio, the biggest thing to remember is, again, the interval dosing is kind of written out here, but the biggest thing to remember is that April 1st, 2016 date. So why does that matter? Only trivalent doses count as valid for the US polio vaccination schedule. And this would be written out as IPV. If we take a look at that previous record, you see the boxes are there for IPV and OPV. Nothing was really indicated. So we'll go ahead and assume that it was not that IPV that we need to count as legible or as valid. So prior to April 1st, 2016, trivalent OPV was used throughout the world. And in 2016, all the countries that were using OPV switched back to monovalent or bivalent OPV, which is not valid in the US. So if the record has oral polio or an unspecified polio vaccine route, we cannot count it as valid if it was given after April 1st, 2016. The only time that we do is if it was given, if polio is indicated that it was given as a part of a combination vaccine, like a pentavalent or hexavalent that had that IPV component inside it. So we'll assume that that was an IM administration rather than an oral. Another little note about polio, if they're under 4 years of age, they only need 4 doses. And that interval between dose 3 and 4 is 6 months. However, if they're 4 years or greater, they only need 3 doses. And that interval between dose 2 and 3 would be 6 months. I'll open up the poll for the next question. Is this 6-year-old patient up to date on the HIB series? So again, the arrows kind of indicate, it's a little bit of a different record, kind of threw it in there so you can just see what different countries, how they write their vaccines. But if you follow that arrow in that second column, it's specified DPT plus HB plus HIB. And in parentheses, it says pentavalente. So there's 2 rows of that. And in that far left column, there's the dates. I went ahead and wrote them out or typed them out on the left side so it'd be a little bit more clear. So are they up to date in their HIB? They were born September 30th of 2016. And that last dose was given when they were almost 2 years old, so a little bit under 2. I still see some people answering. Okay, we'll stop the poll. So yes, they are up to date on their HIB series. So we'll take a look why. So biggest reason, like I mentioned here, that last dose they were given right under 2 years of age. The minimum age that they can receive it is 6 weeks, and the max age would be 59 months if otherwise healthy. So per the CDC, since this patient has received at least 1 dose at the age of 15 months, no further doses are needed. If they are unvaccinated with HIB between 15 and 59 months, you would give only 1 dose and then they would be up to date. However, if this patient is 60 months, which is 5 years of age or older, they are not considered high risk, so they don't have an illness that we're concerned about, they would not require a dose for the catch-up series of HIB. So that 5 years of age is kind of also a cutoff for receiving a HIB dose if they are healthy. We'll open up the poll for the next one. How many PCV13 doses are in this record? And again, a different format and a different layout for the vaccine record. And it's just a way for you to kind of pick out the PCV13 from this record and just kind of work through it, seeing a little bit different of a format. And we'll open up the poll here. Again, even though it's in Spanish, you can kind of make out the initials, and the dates are written fairly clearly. Okay, so we got about 50-50. Somebody else said 2, somebody else said 3. And I went ahead and highlighted them here. So there are 3 doses of it's pneumococcal, but that's our PCV13 that we'll go ahead and count for this patient. And there are 3 in this record. So for PCV13, a little bit similar to that HIB that we were talking about in that age cutoff. The biggest takeaway is healthy children aged 24 to 59 months with any incomplete PCV series would receive 1 dose of PCV. Just a little bit more information on this slide. Again, the interval dosing, that 4 weeks, kind of following the other vaccines that we talked about. We'll open up the poll for this next question. Is this patient up to date on their meningococcal vaccine? So, sorry. The date of birth is 8/19/13, and they received 1 dose at the bottom here, marked by the red arrow. The date is October 12th, 2018. So they were about 5 years of age when they received this dose of meningococcal vaccine. Would they be up to date? So again, kind of split choices. So this patient is not up to date. So let's take a look why. So per the CDC, the patient needs to receive that first dose at 11 years of age. That second dose will be given at 16. If we take a look here, that patient was only 5 years of age, so they're not up to date on their vaccines. So at this point, they'll need to be redosed. However, if they receive dose 1 at 16, that will be their 1 and only dose. That interval that we see here at the top of the screen, interval between dose 1 and 2 is 8 weeks. It only really affects the vaccine administration if the patient were 15 today and turning 16 in a week. That patient will have to wait the 8 weeks in between both doses. So he wouldn't receive that second dose once he turns 16 the next week. We'd have to wait that 8-week window for him. Patient is 16 years old today. Is this HPV dose valid? We kind of saw this record earlier, but it's marked by VPH, which is HPV in Spanish. And we see a clear date. Yeah, I think everybody answered that one correct. So no, unfortunately, it's not valid. Biggest reason, like Cassandra had mentioned, it has to be in pen. Unfortunately, this is in pencil, probably indicating a return date for that patient. And we would not be able to count it today since it's not written in pen. For HPV, they can receive the vaccine as early as 9 years of age, both boys and girls. It's not a school required vaccine. So as providers, it's our job to just educate and encourage the HPV vaccine for their protection. For the interval, under 15, they would only get 2 doses, which we kind of try to use as a point to entice them to receiving it as early as possible, but also starting the HPV series earlier, closer to that 9 years of age, has better uptake and just better overall protection for the patient the earlier we start. However, if they decide to wait and start at the 15 years of age, they would have to get 3 doses. Between dose 1 and 2, you would wait 1 to 2 months. Between dose 2 and 3, it would be 3 months. And then ensuring that dose 1 and dose 3 have been at least 6 months apart. Ultimately, it is the patient and parents' decision because this isn't a required vaccine. Again, just lots of education on our part as providers. We'll open up the poll here for this final question of the presentation. Does this patient need an influenza booster today? So this patient, we'll say that is 8 years of age. Dose 1 was given 4-4-11, and this one's at the bottom here, again, written in pen. And after you see so many, like the better practice you get. But 4-4-11 is 1 day, and dose 2 is 6-6-11. And we have about 50-50. So no, they would not need a booster. So let's take a look why. The patient received 2 doses within the same flu season prior to July 1st. So they will not be getting a booster. They will receive 1 dose every season from now on. So ages 6 months through 8 years old, it's 4 weeks apart for those doses. If this is the first time they're receiving the flu vaccine, if they have not received 2 doses within the same flu season before July 1st of the current year, and if their vaccination history is unknown, like the mom can't remember if they've ever had a flu vaccine, they'll have to get 2 doses 4 weeks apart. However, patients that are 9 and above, they only receive 1 dose per influenza season. Okay, and just some common clinical pearls, something that just to kind of wrap up a little bit, just to highlight the importance of combination vaccines. So typically these are more common for patients 6 years old and under, in the variety of combo vaccines that we kind of see in the States: Kinrix, Vexelis, Pentacell, Pediatric, ProQuad, which is your MMR, and just familiarizing yourself with what the age requirements are. Can this be given as a booster dose? Who is eligible to receive these doses? So we, again, once they're getting 4, 5, 6, 7, 8 vaccines in one sitting, it'll save them a little bit of pain while they're sitting there getting their vaccines and catching them up. So just kind of knowing what they can get, and also understanding that foreign countries have the pentavalent, hexavalent, hexazine, and knowing what all those include per country. So some countries will have it specified and written out in parentheses what that pentavalente includes, or that hexavalent vaccine includes, and just knowing what all is inside that combination vaccine. Also remembering that April 1st, 2016 key date, and knowing why and when we can count the polio vaccines, and making sure that if there's no documentation of it being IPV versus OPV, we'll go ahead and count it as an OPV vaccine at this time. Another bit of information is calling the CDC. We have the number here. It's fairly easy. We tried yesterday just to kind of practice and asking a couple of questions, and it's super easy to get a hold of somebody. And if you run into a situation where you're just not sure which one to count or what vaccine is given next, this is a great resource to kind of have somebody like on standby to be able to communicate with them and ask them a question to verify what's best for the patient today. And also immunize.org, cdc.gov, and the CDC vaccine schedule app are great resources to have on hand, just kind of like looking through and referencing charts real quick. There's great algorithms that kind of go through what is necessary for the patient. If they have this, if they meet this criteria, what would you give? So whenever you come across those records that are a little bit troublesome, those are great resources to have with you. I think, do we have some time for a case study? Go ahead and open up here. The case study for this one will be a different QR code. If you want to go ahead, I'll give a couple seconds to open up the QR code on this screen, and we'll go through a couple questions together to close off the presentation here. Okay, so this first question. Patient is a healthy 6-year-old that has never received influenza vaccine. Which of the following is correct? Okay. So the patient, because they are a healthy 6-year-old and has never received the flu vaccine, they would be getting 1 dose today and dose 2 in 4 weeks, as long as you're in that same flu season. Next question. Patient in clinic is a healthy 17-year-old male. He states he would like to complete the HPV series. Upon reviewing his record, he received HPV dose 1 on his 13th birthday, which is correct. Give dose 2 HPV vaccine to complete the series. Would you give dose 2 HPV vaccine today and dose 3 in 3 months, or inform the patient that HPV vaccine is only for female patients? So this one's a little bit tricky, just because they already passed that 15 years of age cutoff. But because they started the HPV series before they turned 15, we'll go ahead and give them credit and kind of just grandfather them into that only 2-dose series. So they'll go ahead and just get that 2nd dose today, and then they'll be up to date for HPV. That last one, it's for female patients only, kind of a myth. Some people believe that's only for girls, but again, informing, the more education you provide to the families, the better off they are making an informed decision. The next one, patient is a healthy 6-year-old female. She has received the following 6 oral polio doses, and the doses are kind of written out here, kind of 2 months apart each, and then almost at a year mark. Regarding polio, which is correct? So yeah, we talked about how oral polio, unfortunately, cannot take it if it was after that April 1st, 2016 date. So they would need to restart the IPV series today, give dose 1 today.
Okay, I'm back. So today we have a healthy 4-year-old patient in clinic. They present a vaccine record with 1 SRP that was given at their 1st birthday, and then the 2nd dose of an SR that was given at their 2nd birthday. Which of the following is correct? Are we going to give an MMR vaccine today, or are they up to date? So that is correct. We would give the MMR vaccine today because that 2nd dose, although the interval was actually fine, it only has to be a month apart. I know that in our country, we give it at 1 and then we give it again at 4. If that 2nd dose had the SRP, the measles, mumps, and rubella, we would actually count it. But in this case, we're not, and we would give them an MMR vaccine today. Next. Thank you. A patient is a 16-year-old healthy male requesting an MCV series that's required for school. Which of the following is correct? Are we going to give a dose of MCV today and no further doses? Are we going to give a dose today and ask them to come back in 8 weeks? Or are the patient's not eligible to receive the MCV vaccine? So what do you guys think? So the majority of y'all say, give him his dose today and then no further doses. And that is actually correct. So if they miss that 11-year-old dose, we don't go back and revaccinate the series. We would just kind of start with today, and he would just kind of get the 16-year-old dose and go from there. He wouldn't get a 2nd dose. Next. And this is the last one. Patient is a healthy 6-year-old female, has never received the HIV vaccine or the PCV13 vaccine. Which of the following is correct regarding HIV and PCV13? So is the patient not eligible to receive HIV or PCV13? Are they only eligible to receive the HIV dose? Are they only eligible to receive the PCV13 dose? Or are they going to receive both doses today? And all of you said they're not eligible, and that's correct. If it is a healthy, child, you age out at the age of 5 at 60 months for the HIV and the PCV. So you have to be 59 months and under to get it. Once you hit that 60-month marker, you're only going to get it if you have some underlying medical condition. But this one was a healthy child, so we would not give her HIV or PCV13. So we'll go back to the presentation. Those are our references, and here we have a QR code. We ask all of you to take a little bit of your time, maybe like 2 minutes, to fill this survey out about how the presentation went. We'd appreciate any feedback as well. We thank you guys for all of your time. I did answer some questions in the chat. Okay, I answered all 4 of the questions that we had in the chat, because I think we are out of time. Christy, is there anything else?
No, okay, yeah, I think that was all of the questions. And then, you know, if there's any other additional questions, we can just reach out to you guys. Would that be okay?
That'd be perfect.
Okay, what an amazing presentation. Thank you for making it so interactive, so informative. We really appreciate you.
Thank you for having us, Christy, and thank you for inviting us. We really enjoyed, making it and sharing all this, lots of knowledge that we gave you guys tonight, and we hope you all enjoyed it.
Thank you.
Wonderful. Thank y'all so much. Thank you.
Okay, thank you.